Good evening. I'm Ashley Reef, the nurse coordinator for the Adult Congenital Heart Disease program here at Houston Methodist. Before we get started this evening, I'd like to tell you about a really exciting opportunity that our program's been afforded. We've been awarded the PCORI grant to build patient-centered outcomes research. As part of this, we're holding an informational meeting. Now, what is PCORI, you might ask? Well, what we're looking for is we're trying to recruit patient stakeholders that represent a population as colorful as our region. We want to train them in research methods and enable them to be equal partners in outcomes research. If you think you might be interested in this opportunity, you can join us for an open house Saturday, February 13th from 2:30 to 4:30. Now, let's get to CV Live. Tonight, we will be discussing women's heart health and congenital heart disease in pregnancy. We have three great guests with us who've been kind enough to share their time. Here with me in the studio is Dr. Valeria Duarte. Dr. Duarte is an adult congenital cardiologist with expertise in advanced cardiac imaging, pregnancy, and cardiovascular disease. Thank you for being here, Dr. Duarte.
Thank you for having me, Ashley. It's a pleasure.
Joining us virtually is Dr. Patricia Bellows. Dr. Bellows is an assistant professor of clinical obstetrics and gynecology at Weill Cornell Medical College. Her interests include general and high-risk obstetrics, adolescent gynecology, and minimally invasive gynecologic surgery. So happy to have you with us, Dr. Bellows.
Thank you for having me. This is great.
Also joining us virtually is Greer Weeks. Greer is a congenital patient who's followed by the ACHD team here at Methodist and has recently given birth. Thank you for joining us, Greer, and being willing to share your story. We want tonight to be very interactive, so please send us any questions and we will address them as we move through the program. All you have to do is text DEBAKEY to the phone number 37607. That's DEBAKEY to 37607, and we'll be happy to answer your questions. Now, let's get started. So I want to start with you, Greer. Can you briefly tell us a little bit about your heart defect?
Sure. So I was born with transposition of the great arteries. And so because of that, I had a sending procedure when I was 4 months old. And the day that I was born, I had a balloon septostomy. And then when I was 4 months old, I had open heart surgery and the sending procedure.
Okay, and how about growing up? Did you encounter any difficulties after you'd had your surgeries?
No, ma'am. I'm very fortunate. I did not. It has not held me. My heart defect has not held me back one day of my life. So I've been very fortunate in that way.
And how about as you got older and you decided to start a family? Did your heart defect affect your family planning at all?
Oh, I think we lost her. Let's give her a minute to reconnect.
Nope, I think we lost Greer. Well, while we're waiting for Greer, Dr. Bellows, I have a few questions for you.
Absolutely.
When you are taking care of a patient that comes to you that has heart disease, what's different about that than when you're caring for a patient that does not have heart disease?
The main challenge in caring for patients during their pregnancy when they have a congenital heart disease is coordination of care and being in a center where we have the ability to have kind of a multidisciplinary approach between cardiology, obstetrics, maternal fetal medicine services, and also obstetric anesthesia. So, that's the main challenge, is the coordination aspect. And, it's very important to prepare in advance of pregnancies as well. You were asking Greer how her family planning was affected by her family or by her personal history of heart disease. And, I'll say one of the most important things that women can do in advance of a pregnancy, if they have a known congenital heart issue, is to coordinate care with a doctor and an obstetrician and a cardiologist in advance, so that they know the risks that could be ahead of them and what they can do to minimize the risk moving forward.
Okay. And I see we have Greer back. So Greer, did your heart defect?
I'm sorry, my Wi-Fi.
That's okay. The danger of having virtual meetings, right?
Virtual live meeting.
Right, virtual life. So as you were getting older and you were starting to plan, for a family, how did your heart defect impact that, if at all?
It really because I would be a teacher. Now I'm a stay-at-home mom, but and so my cardiologist growing up has known that children have been a big part of my life, and that I've always wanted to have children. And so I've kind of asked him from early on, will I be able to conceive one day? And he's always said that my heart shouldn't stop me, and that it shouldn't really have a problem, and it didn't, fortunately.
Now I know that as you were getting ready to start your family, you did encounter a few bumps in the road. Would you be willing to share those with us?
Sure. So my husband and I went through infertility for 5 years before I got pregnant. And so we went through 2 rounds of IVF, and they were unsuccessful. And so once those were unsuccessful, we had to go a different route. And we went to a doctor at Methodist that was wonderful. And he kind of did the more natural approach. And it's the Creighton model is the system that he uses. And so I had I had 2 different fertility surgeries to fix my underlying issues, which I had like endometriosis, and I had a wedge resection. And so he fixed that. And then my husband and I were able to conceive naturally. So I went through that for about 2 years. So all it was a 5-year journey.
Okay. And Dr. Bellows, as Greer came to you, I know you were her or are her OBGYN. As she came to you, what was kind of your first move? Did you refer her to cardiology right away?
Well, Greer was very organized from the start and had always had very good medical care, and she had stayed on top of her cardiology care her whole life. And in terms of family planning, she had been very open in communicating with her cardiologist her plans. And that goes a long way in women who have complex medical conditions, to try and optimize those conditions before you're pregnant. So, in Greer's case, she actually was already very well established with her cardiologist in Alabama. So it was a matter of getting her established with cardiology here at Methodist. And we're fortunate to have a very good cardiology team and a lot of great staff members who were able to see her and care for her over the course of her pregnancies. So when she came to me, the first thing as an obstetrician that I do is, treat the pregnancy and diagnose the pregnancy. But the second thing is coordinating all of the other things that we need to do to make the pregnancy smooth. That involved getting Greer in to see a maternal fetal medicine specialist, which is a high-risk obstetrician. And she also, got in to see Dr. Duarte to try and, optimize her blood pressure control, make sure her cardiac function was good, and make sure that she could have a healthiest pregnancy as possible.
Okay. And Dr. Bellows, could you tell us, since you were talking about having a healthy pregnancy, what things can any woman with congenital heart disease, as she's going through pregnancy, what can she do to maximize the health of her pregnancy?
Yeah. So, it's important to, before you conceive, have a very frank discussion with both your cardiologist and your OBGYN about the risks that your specific condition could pose during pregnancy. There are some cardiac conditions that patients can have a very well tolerated pregnancy, and of course there are others that might not be so well tolerated. So it is important from the start, before you even conceive, to have this discussion with your OBGYN and your cardiologist. Now, aside from that, the simple things that a woman can do to take charge of her personal health and optimize her pregnancy are maintain healthy weight and healthy diet, optimize blood pressure control if that is an issue for them, and optimize any other comorbid conditions like diabetes or thyroid dysfunction. So really controlling and, trying to get a handle on all of the other comorbid conditions before you conceive is really important. And ideally, having discussed the underlying cardiac condition with the cardiologist and obstetrician beforehand, so that when a pregnancy does occur, we know the next steps that we need to take.
Okay, and Dr. Duarte, I know that Greer came to see you then, and what were things that you did to help her ensure a healthy pregnancy?
Well, yes, Greer came. She was very organized, just like Dr. Velo said, and she knew that she needed to have all the right team to accompany her in her journey. So when a patient with adult congenital heart disease, just like Greer, comes to me for the first time, especially in the setting of pregnancy, the first thing I need to do is to learn about them as much as I can. As Dr. Velos mentioned, Greer had previously followed in different states. So my first step was to get to know her, hear her story, obtain her records, her operative records, and all the pertinent information to help me re-stratify her and see what I needed to monitor throughout her pregnancy. And this is different in every patient. That's why we need to provide individualized care for these very special patients with congenital heart disease. In Greer's case, she had a history of arrhythmias before, and she also had a history of conduction abnormalities, and she had a pacemaker. So my job was to go back and look at those issues and see how could I optimize them throughout her pregnancy with medications, and what did I need to look for. In patients with congenital heart disease, it's important to be very aware of the risk of heart failure needing diuresis, and also the risk of arrhythmias. Those are the main two things. And in a patient that had a history of arrhythmias before, then we need to be very vigilant throughout pregnancy and make sure in her case, we could monitor her rhythm through her device, and she was super helpful with that, facilitating the transmissions and so forth, and optimizing the medical regimen and having a plan. Like Dr. Velo says, coordination of care is key here. And so when we anticipate what could happen, we not only put a plan in place to prevent things from happening, but also we have a plan of what would we do if this happens during pregnancy. What happens if she has an arrhythmia during pregnancy? What happens if she has an arrhythmia peripartum? How do we address this? And also alert the other members of the team, because as Dr. Velos mentioned, the team involved Dr. Velos, an MFM specialist, and an anesthesiologist from the OB department, and then the cardiology department, the labor and delivery team. So it's a big team that needs to be very familiarized with the patient and the plan in order to make sure that everything goes smooth, and pregnancy and delivery are a smooth journey for the patient.
So speaking of smooth journeys, I know that you did have a pretty smooth journey, Greer, along the way. So was there anything that was really different than you expected?
Greer, we cannot hear you.
I think you're on mute, Greer.
Okay, sorry.
Good.
That's
Can you hear
fine.
me
Now
now?
it's good.
We
Now
can hear you.
Okay, so I'm sorry, will you ask the question again, please?
Sure. You had a pretty smooth journey. I know that. But along the way, was there anything that seemed a lot different than you expected?
Not really. Like they said, I was in great care, and I was born with this heart defect, so I've kind of just
learned to trust the doctors, and that's what I do, just kind of whatever they tell me to do. And so the only really thing that I really, from a heart standpoint, is the arrhythmia, like Dr. Duarte said. And we switched medicines from labetalol to metoprolol towards the end of my pregnancy. And that really helped with my arrhythmia, and I wouldn't get those little tachycardias as much, those little procedures. And so that really helped, but that's really the only thing.
Okay. And do you feel like you were well prepared for the whole journey, what to expect at delivery and postpartum?
Yes, ma'am. I do feel like I was. The only thing that really kind of threw me a loop was after my C-section, I had my blood pressure kind of went up and down and up and down, but we got that figured out with medicine. The team of cardiologists and Dr. Bellows, they were on top of it, and it was fixed within a day. So just with medicine.
Okay, and you had a C-section. Now, Dr. Bellows, does a patient with heart disease have to have a C-section? Is mode of delivery controlled by that?
Absolutely not. In fact, with deliveries in general, a vaginal delivery is a much less risky procedure for most patients because there's less blood loss, there's less infection risk. In Greer's case, she ended up
We lost Dr. Bellows.
It looks like we lost Dr. Bellows.
the labor process itself. Can you hear me?
We can now. We lost you for just a couple minutes.
Sorry. So I was
okay.
saying that we actually tried to induce Greer, and in the process of her induction, due to complications with the induction, we ended up needing to do a cesarean. So by no means is a cesarean something we do outright in all cardiac patients. In fact, a vaginal delivery for most patients has less blood loss, less infection risk, and overall is a less risky procedure. It depends on the specific patient. Patients who cannot tolerate Valsalva or the pushing effort, those are patients who we might need to consider a primary cesarean outright. But for patients like Greer who have a really good functional status, ideally an uncomplicated vaginal delivery is the least risk to them.
Okay, and Dr. Duarte, I know that there are certain cardiac defects that are a little bit riskier to even get pregnant. Could you discuss maybe low, medium, and high risk defects and kind of how you might manage some of those differently?
Sure. So that's a complex discussion. I think it has to be, and by complex I mean some patients with simple defects may have complications. So patients may have an ASD or a VSD, but that can be a simple defect without complications for some patients, but other patients may have had enough shunt to cause right ventricular enlargement, right ventricular dysfunction, arrhythmias. Some of them may have pulmonary hypertension. So it's very hard to categorize patients by risk categories based on their specific defects. So we need to, like you were mentioning,
I had to switch to my phone because my Wi-Fi was not working for some reason. So
perfect.
I know you probably couldn't hear me at the very beginning. I could hear you once you clicked over. Okay, good.
Perfect. You're perfect now, Greer. So it's very individualized. So for every patient, the reason why we stress that they should be seen and evaluated before pregnancy, it's because we need to update their imaging, their exercise, assess their functional capacity, make sure that there isn't anything that we need to address before pregnancy. There are some defects that can be addressed before pregnancy. Some patients will need an intervention to optimize their hemodynamics prior. And for others, like Greer, is just identifying risk factors and what to monitor and what to keep an eye on and what to anticipate. So to your question, Ashley, it's very individualized. So we just need to take one patient at a time and assess their defect, the complications, their history. In that way, we can have a comprehensive approach to their care. There will be patients that are too high risk for pregnancy. Fortunately, those patients are a minority. And we do have that very frank discussion with them about the risks of pregnancy. But it's always important to take into account what is important for the patient and try to support them in their journey of becoming a parent, whatever that may mean for them.
Okay. Now, it seems like frequent follow-up is probably important and being monitored closely. Dr. Bellows, how often do you follow up with patients when they're pregnant and they are seeing maybe maternal fetal medicine as well and cardiology? How often do they see you? Dr. Bellows, can you hear us? Well, let me ask you, Dr. Duarte, how often do you have patients follow up along the way when they're pregnant?
So it depends. Everything depends. At the very minimum, I see them one per trimester. And usually we'll have imaging, and in between we check the blood pressure. We're in contact in between visits. But if there are patients that
Can you see them?
No, I cannot.
Okay, yeah, me either.
Oh, they cannot see us. Okay, let's continue. So there are some patients that are going to need closer monitoring, especially those that we are addressing an issue. So, for example, in Greer's case, she was having palpitations. We interrogated her device. She was having some runs of atrial arrhythmias. So then that led to adjusting her medications
Oh, it
to
looks
see
like they're muted.
if that would work.
Ew.
Okay.
I can't even see them.
Yeah. So,
Okay.
can you hear us now, Greer?
Now I can hear you. Now we can hear you.
Okay, fantastic. So let me recap. Ashley was asking me how often, and that's a question for Dr. Bellows as well. So I'm just going to answer it from a cardiac perspective. How often do we see our patients with cardiovascular disease who are pregnant? And I was telling her that this is tailored to the patient and the patient needs. From a cardiovascular perspective, I see my patients at least once per trimester, and these are patients with very smooth pregnancies who are not having issues. But if I'm addressing an issue, then I will see them more frequently and make sure that everything stabilizes. For example, as Greer was saying, she was having some atrial arrhythmia, so we interrogated her device, and then we made some adjustments to the treatment. So we follow the patients until things settle down, and then we can monitor from afar. There are patients that have very difficult to control high blood pressure, and we need to see them very, very often to make sure that the treatment is working and adjusted as needed. We have patients that have heart failure during pregnancy that need diuretic treatment, so we need to monitor their weights and their volume status and tailor the diuretics. So it depends on the patient's needs. And so I would say that we see them as often as is needed to keep them safe and well controlled. And I'm going to let Dr. Bellows tell us from an OB perspective, how often do we follow the patients?
Sure. Standard obstetric management is in the first and second trimester, we see patients monthly. In the third trimester, every 2 weeks until the last month, and then weekly. Now, for patients with congenital heart issues, if they're healthy and very stable like Greer, we don't really need to deviate very much from the standard management with Greer. She did so well that I just saw her routinely. But you're absolutely right, Dr. Duarte. For patients who are watching their blood pressure more carefully, those patients have to come in a little bit more frequently for examinations, for lab assessments. And some patients ultimately require what's called antenatal testing, where we do more frequent monitoring of the baby toward the end of the pregnancy if we're worried about any fetal outcomes.
Okay, now let's say that a pregnant patient encounters a problem, Dr. Duarte, along the way. How do you manage that?
It depends on the problem. So there are problems that we can manage as an outpatient with close follow-up and medication adjustments and with patient engagement, because our patients need to send us their blood pressure logs, their weight logs. They sometimes need to get lab work for us to monitor their kidney function. So some problems we can address as an outpatient. Sometimes patients need to get admitted, and this can be for a short period of time just to compensate them, and some others for longer. So this also depends on what the issue is, how stable or unstable the patient may be. But fortunately, most of our patients do very well through pregnancy, and we're able to manage them as outpatients most of the time. We watch them very close during the third trimester and as they get closer to their due date, because that's when the volume, the plasma volume is the highest, the cardiac output goes higher, the heart rate is higher. So we watch them very closely then, and also in the postpartum period.
So speaking of postpartum period, what does a congenital patient that has a baby in the postpartum period have to continue to follow up with you, Dr. Bellows?
Absolutely. So, while they're in the hospital, of course, we're seeing them daily. And generally speaking, for postpartum care, I see moms, between 1 and 6 weeks after delivery, depending on their needs in specific situations. Like Dr. Duarte said, the postpartum period is often the most risky period for these cardiac patients who have delivered, because all of the postpartum volume shifts that happen can be very difficult for some of these patients to tolerate. So a lot of what we do in managing labor and managing the postpartum period all comes to kind of a head after delivery. The first 24 to 48 hours after delivery are the most high-risk time for a lot of these patients. So we watch them very carefully, and that's a time period where we have very involved care from both the cardiac side, the obstetric side, the anesthesiology side, to try and make this transition as smooth as possible for the patient. Now, that being said, we still try to make it a normal as postpartum experience as we can. We try to keep the babies in the room with the moms. We try and get them the lactation support that they need. We try to get them all of the routine postpartum support that they would have otherwise. But they have the added component of needing to be monitored very, very carefully from a cardiac standpoint.
And Dr. Duarte, how often do you follow postpartum patients after they've had their baby and they're on to being just congenital patients? Not that you're just a congenital patient.
So we support them peripartum. So we collaborate. For example, when we were planning Greer's delivery, we met with Dr. Bellows and also with the MFM specialist, and we had a discussion, and they alerted us as soon as she was coming to the hospital for induction, and we follow our patients peripartum, so from when they're being induced, and then if our help is needed through delivery, we're there as well. And then we see them every day while they're in the hospital, adjust their medications, and make sure that they remain stable and their volume status is good, that they don't have arrhythmias, and then we see them in clinic. Patients that have active issues that we're monitoring, for like Dr. Bello said, postpartum we have a fluid shifts that sometimes can trigger some responses, like heart failure, and our patients may be slightly volume overloaded postpartum. So those things, if we are actively addressing these things, I usually see them as soon as within a week postpartum. So patients that are very stable and do very well through labor, we can space that. But all the patients need to have a postpartum follow-up with their OB and with their cardiologist. And then we return to our routine follow-up after that.
Dr. Bellows, when in the postpartum period, when is the best time to start that discussion about contraception?
Actually, that's often a discussion we start during the pregnancy. It's something that you can never talk about or think about too soon, even though we might not be keen on certain hormonal methods before the 6-week postpartum visit because of blood clotting risk. It's always a good idea to have a plan in place. You know, a lot of these congenital heart patients have a lot of complex issues, and they need to have a plan in place in terms of contraception because their pregnancies need to be planned and coordinated and their health needs to be optimized. So an unexpected pregnancy or surprise pregnancy can pose a significant risk. So contraception counseling is an important thing from the get-go.
Okay, and Dr. Duarte, do you discuss those things as well?
Yes, absolutely. And contraception, like Dr. Velo said, is very, very important and needs to be discussed because sometimes the patients, that way the patient can express what their expectations are, what their preferred methods are, and they can be informed. And there are patients when pregnancy is complicated where contraception is paramount because after successful delivery of their child, we want to make sure we address the issues that started during pregnancy before another pregnancy, and I think Greer is a good example of that too, because her atrial arrhythmias, she did have an episode peripartum, and then but this was addressed in the postpartum period as she was planning another pregnancy. Is that right, Greer?
Correct.
And Greer, how was your postpartum period? Did you have a fairly smooth postpartum period?
I did. Like I said, you know, I had the tachycardia. Is that the right, Dr.
Yes.
Duarte? Is that right?
Yes.
Okay.
Yes.
I had those little periods and stuff, and the medicine really helped that. But I had the tachycardia even before I got pregnant, and so an ablation has always been kind of on my radar one day. But like you know, we went through all that infertility and stuff, and then we got pregnant, and so and my heart was doing great, so we planned. And I did have an ablation after my son was born, so I guess maybe about 5 months after my son was born, I had an ablation to help with the tachycardia, the arrhythmia.
And how have things been going since then?
They've been going good. I can tell a difference.
And how's your little boy doing, more importantly?
Oh, he's great. He's very busy.
Dr. Duarte, just some basic questions. Can you just talk to us a little bit about how the heart changes during pregnancy?
Yes, absolutely. So pregnancy is a very special journey for our patients, but also a special journey for their bodies and their heart, because there are many changes that happen. The plasma volume increases, the amount of red blood cells increase, the heart rate increase, the vascular resistance decreased. So there are many changes that the women's body go through in order to prepare and support the pregnancy. So that's why it's very important for us to optimize what can be optimized before pregnancy. And that's key. If there is one message that we can take away from a cardiac perspective is, if for patients who have a cardiovascular disease who are considering pregnancy, it's very important to have a meeting for counseling where their clinical status is evaluated, and if there is anything that can be optimized in preparation for pregnancy, then that is done. And also it's important to meet to talk about risks and expectations and put a team together to support the pregnancy.
Okay. Now, I guess my question is, what are there risks to the baby of being pregnant if you have congenital heart disease?
Yes. Well, yes. Patients who have cardiovascular disease are in increased risk for complications for the mother and for the fetus. So the answer is yes. Our patients with congenital heart disease can have babies that have the growth is maybe slower, and they need to be evaluated. We recommend a fetal echocardiogram for evaluation to evaluate the baby's heart to know if there is anything that needs to be anticipated in preparation for delivery. So yes, there are some risks for both, but our job is to try to optimize and minimize the risks as much as possible, and have a contingency plan and anticipate potential issues. Yes.
Okay, and I see we have a question from our audience. Except from usual indications for antithrombotic therapy, for example AF or VHD, which CV patients' diseases can benefit from it during pregnancy? So Dr. Duarte, do you want to take that one?
Yes, of course. Yeah, as that's a very good question. As mentioned in the question, patients who are already on anticoagulation, we need to continue anticoagulation. Now the regimen is often different because during pregnancy there are some adjustments. There are some medications that if they're at high doses, like warfarin, need to be adjusted. In general, pregnancy is a prothrombotic state. So in patients that have had history of thrombotic issues, in those we will discuss. In general, if they have completed their anticoagulation, we will discuss initiating prophylactic anticoagulation during pregnancy. And we work together with the obstetricians on that. Dr. Velos, do you want to say something about anticoagulation approach?
So, you're absolutely right. Pregnancy is a very prothrombotic state, and the postpartum period as well. So for all of the typical indications, we would give prophylaxis or therapeutic anticoagulation as needed. Patients with mechanical heart valves, patients with a history of DVT, PE, for those patients, of course, we would want them anticoagulated. And the decision for therapeutic versus prophylactic just depends on the patient's individual needs. So it's a multidisciplinary approach.
Mm-hmm.
For those patients who do require, anticoagulation, that extends through the 6-week postpartum period, typically also.
That's a very important point. And anticoagulation is one of the challenges of pregnancy. Women who are anticoagulated during pregnancy do have an increased risk, an increased pregnancy risk overall. So it's something that needs to be individualized and carefully managed. Some patients are in warfarin at higher doses, and they need to be transitioned to other anticoagulants, like heparin-based anticoagulation, and we need to monitor different with laboratory tests. We need to monitor their levels and make sure that they're therapeutic throughout. We need to have a strategy if they're in low molecular weight heparin, to have a strategy to plan when they go into labor. How do we transition them to a shorter acting heparin through labor? When do we stop it? Is the patient going to have epidural anesthesia? All those things are taken into consideration in the management of anticoagulation. It's a complex thing to manage, but a good team can manage it very well and be very successful.
And Dr. Bellows, while we're on the topic of medications, what other cardiac medications kind of throw up a red flag for you as a patient comes to you for the first time to confirm pregnancy?
Well, for patients who are on medications, prescription medications, anytime someone comes in pregnant, we go through their medication list and tailor it to what's appropriate for pregnancy. For patients who are on anticoagulation, that's a very good, for people on warfarin, we obviously have to stop that early on in the pregnancy and transition over. But, it just depends on the patient's specific situation and, whether they have congenital heart issues or other medical issues. Going through the medication list at a new OB visit is one of the first things that we do. And for congenital heart patients, often they will be planning the pregnancy in advance. They will have had preconception counseling. So their medication list usually is tailored, and they know to call Dr. Duarte as soon as they have a positive pregnancy test and say, hey, I really need to, tailor my medications and get off of the teratogenic meds.
Okay, and Dr. Duarte, are there any meds that, if it's a new patient to us, that you go ahead and you change and that when they come to you pregnant?
Yes, there are some in patients who are in childbearing age and are on those medications. I make a point to discuss this with them during the clinic visit. So like Dr. Velo said, so the moment they get pregnant, they know to call so we can transition them to other medications. Some frequent examples are ACE inhibitors, lisinopril and alapril. Those are ARBs, losartan, valsartan. Those are medications that we transition to other more pregnancy-friendly medications because of the fetal risk. And then antiarrhythmics are others that we need to take into account, like amiodarone. We have patients that are on amiodarone, and in those patients, we really need to get together before they get pregnant to have a plan on how are we going to manage their arrhythmias without that medication. And sometimes just transition them to the other medications, make sure they work for them before they get pregnant. So yes, medication is a big part of what we do. Yes.
And you have those conversations beforehand, correct?
Exactly. So there is an initiative called One Key Question where patients, women in childbearing age should be asked during their cardiology visit, is there any possibility that you may get pregnant in the next year? And that opens that conversation, and we discuss, well, it's important to know because if you were to get pregnant, you're on these and these medications that you shouldn't be continuing in that setting. So it's a lot of education because sometimes patients have been on those medications since they were kids, and they would have never imagined that the medications that help their heart for some reason are not safe during pregnancy. So we make a point to discuss this with our patients, yes.
Okay. We have a follow-up to our antithrombotic question. Are there any CV patients with no indication for antithrombotic therapy outside pregnancy that can benefit from antithrombotics when pregnant? Dr. Bellows, we can start with you on that one as well.
Well, there's patients all the time who we end up starting on prophylactic Lovenox during the pregnancy and after the pregnancy who wouldn't necessarily have an indication during the pregnancy because of various issues that come up. So, in terms of specifically congenital heart patients, I'll let Dr. Duarte address that, but it's not infrequent that I end up putting people on prophylactic Lovenox during the pregnancy who aren't on it otherwise. And it just depends on the individual person's circumstances.
Okay, Dr. Duarte?
Yes, well, it's again very individualized. When we have some patients where a thrombus could be a very, very high risk, like patients who have a single ventricle, a Fontan pathway, a classic fontan with a very large atrium that for some reason they hadn't met the indications for anticoagulation before pregnancy, then we think really hard in those patients on whether starting anticoagulation is warranted. Yes, that's an example right there. Yes.
And sorry to interrupt, but just wanted to let you all know, of course, we have a very low threshold to anticoagulate postpartum patients, especially if they've had a cesarean and have other comorbid conditions. So even if they weren't anticoagulated during their pregnancy, they might require it postpartum.
Okay. That's so nice to hear that it is not something unusual. I think that would definitely put a patient's mind at ease to not think that they're the only one or one of a few that's happening with. I'm sure our patients will feel better about that. Now, what about you, Greer? Did you have any medications that you had to change or you had to stop while you were pregnant?
I did not. I'm trying to think. I did not. Before I was on, I'm sorry, it's hard for me to remember. So before I was pregnant, I was on a labetalol still, I think, because my cardiologist in Birmingham knew that I was always trying to get pregnant. So they switched me. Before that, I took a Atenolol.
Okay.
And so they switched me to labetalol when they knew that I was trying to get pregnant. So I was on that, and then, like I said, after my delivery, I had some blood pressure issues. So Dr. Duarte put me on lisinopril, and but she told, I'm actually expecting my second child right now, and so she told me from day one, she said, when I put you on this, you cannot be breastfeeding or you cannot be, trying to conceive. This very important, so when my husband and I tried to start to conceive again, I stopped taking it and we switched. I think to maybe nifedipine, maybe? I don't know if I'm saying that right.
Yes,
Yep.
nifedipine.
Okay.
See, Greer, you were that patient, you planned ahead. You were the model ACHD pregnant patient, for sure.
Well, I like to hear that. I don't know what Dr. Duarte and Dr. Bellows would say.
Yes. Well, I would ask you what concerns you had along the way in your pregnancy, but I don't. You probably didn't have many, did you? Just judging by your personality.
I really didn't. Like I said, I've always trusted my doctors from day one, and all my doctors that I've always run across have always been very open with me and telling me this could happen or this could happen, so but I've always kind of just left it in their hands. I trust them and what they say. And I guess right when I did get pregnant and we started talking about delivery and stuff, the arrhythmia kind of came in my head a little bit, but then I just realized that just because of the tachycardia that I was having before pregnancy, but the metoprolol, really, really helped me. So that kind of went off my radar then.
Okay. Now, I know you had arrhythmias, and we actually have a question that was sent in that's about arrhythmias as well. For patients with high risk of severe ventricular arrhythmias, if there is no sufficient argument for ICD implantation outside pregnancy, is there a place for a temporary ICD like in loop recording? Dr. Duarte.
Well, yeah, that's a very complex question, a very good question though. I would say that patients that have had severe ventricular arrhythmias, most of them will have a device by the time they get to pregnancy. So we rarely find patients who have severe ventricular arrhythmias, sustained arrhythmias, that become pregnant and do not have a device. In that event, then you do need to be creative, and everything depends on the patient's history. Has the patient had an ablation of that arrhythmia? Is the patient now on a medication to control that arrhythmia? There haven't been big studies showing that heart monitors help other than addressing symptoms. So if my patient starts to develop palpitations and I'm concerned about that, I would give them alarm symptoms. I would put a monitor to see what are the palpitations all about, and then go from there, optimize their medications. But yes, ventricular arrhythmias during pregnancy are high risk, and they need to be taken seriously and monitored closely. We do not typically implant a loop recorder for this indication, but we definitely keep a very close eye on our patients and do external monitors to see what their symptoms are caused by, what's their underlying rhythm, and what's the burden of arrhythmia, and so forth.
Do you ever have patients that maybe have arrhythmias to the extent that they have to be hospitalized and actually finish out their pregnancy in the hospital?
Yes, that patients that have arrhythmias, or in general? In general. Yes. We have had patients that because they need closer monitoring or higher level of care, they are hospitalized before delivery, and in general everything is in thinking about a better outcome. Sometimes we'll have patients who have decompensated heart failure for a myriad of reasons, either an infection, endocarditis on their valves, or arrhythmias. So those patients, sometimes when it's hard to optimize them in the outpatient, it's safer to have them in the hospital and monitor them, adjust their medical regimen, support them, so in order to get the pregnancy as far as possible. And this is thinking about the health of the baby as well. So sometimes patients have issues earlier in pregnancy, so we support them, and sometimes that is in-house, yes.
Okay. And as you're planning for a patient's delivery, I know there's a multidisciplinary group that comes in. Can you talk a little bit through who's involved in that? And Dr. Bellows, I'd love to hear what your part of that piece as well, not just where Dr. Duarte is coming from, but yours as well.
Yes.
Sure. Sorry, go ahead, Dr.
Sorry.
Yes, we work very closely. So we always organize a meeting, at least one meeting, usually early in the third trimester, to discuss mode of delivery, contingency plans. What happens is if the patient presents with an arrhythmia and the blood pressure is low, is that going to change our mode of delivery? Is that going to change the place where they deliver, and the level of care that they need? So we have this meeting where we plan things. If everything goes well and everything is going in the same direction, we have a plan in place, but we also have a contingency plan. We also discuss what sort of monitoring the patient is going to need. Is the patient going to be in the labor and delivery floor? Is the patient going to need ICU monitoring? Is the patient going to need a telemetry monitoring, invasive blood pressure monitoring, all those things? In general, is the cardiologist, the obstetrician, the MFM specialist, the anesthesiologist. Some patients we have in anesthesiologists with expertise in OB care, and then in anesthesiology with expertise in cardiac care. We also talk to the team, the labor and delivery floor team, the OR team, because there is an OR in backup, in case that's needed. It's a very large team. Some very complex patients involve over 20 people in a meeting. Sometimes neonatologists, pulmonary specialists. Yes, but it's always good to have as much support as needed for the patient.
And Dr. Bellows, I know you are such an integral part in that meeting. So talk through a little bit about what your piece is
Yeah. So, I feel like my job is to coordinate all of it and to be in communication with all the different pieces. The main thing that needs to be done is there needs to be a plan in place of what happens when she comes in for her induction, her C-section, or whether she comes in spontaneous labor. And all of those scenarios need to be played through in terms of what is the plan from OB anesthesia, what is the plan from the obstetrician, what is the plan from the cardiologist, where is this going to happen, what is the patient's requirements, what will they need postpartum, what if they end up needing a C-section in the case with Greer. So it's a lot of moving parts, and it's just a matter of organization. None of it is, really complex, but it's a matter of getting everything really well organized and having excellent communication between all of the groups. So as long as, and that's my primary role as the OBGYN, is to make sure that we've got a plan in place. Greer doesn't know this, but she had about a 3-page typed document on the bulletin board in labor and delivery. Look here if Greer is admitted in labor, and it had her whole plan of care and who to call and all contact information, and call this person first, then this person, then this person. And so it was as organized as we could make it. And that's what we try to do for each complex medical patient that we see.
Great. Well, see, Greer, you didn't even know how well taken care of you were. even better than you thought.
I did. I think they are wonderful, so it does not surprise me.
I'm biased, but I agree. We look like we have another question from the audience. Are there any CV drugs to be preferred during pregnancy for more beneficial or less harmful effects on fetal circulation? Dr. Bellows, do you want to address that one?
Well, in terms of fetal circulation, I'll let Dr. Duarte speak to that. But the most common meds that we see cardiac patients on during pregnancy are heart or blood pressure medications. And the preferred medications during pregnancy are going to be labetalol or Bricardia. So, getting that is the most common, transition that we need to make for those patients. Aside from that, it just depends on the individual patient.
Okay. Dr. Duarte?
Yes. So I wouldn't say there is a more beneficial medication. We usually look at the profile of the medications for teratogenesis mainly. So what we keep in mind is to avoid the harmful medications for the patients. I should note that there are medications that we use, like Dr. Bello says, very frequently, and then sometimes we encounter patients that need other type of medications that may not be, there is no medication that is 100% safe during pregnancy. So there are some medications that need to be used with caution, but sometimes we have a clinical indication for them. So we compromise there because we balance the well-being of the mother. The mother has to, if we need to control arrhythmias, to optimize the mother circulation, and that way we're also optimizing the fetal circulation. So we do have sometimes multidisciplinary discussions where we weigh the risks and benefits, and we look at the safety profile of all the medications, but also sometimes we need to support the mom's symptoms and active issues.
Okay, since we're talking about fetal health, one question that I encounter a lot with our patients is, what are the chances of me passing my congenital heart defect on to my baby?
That's a very good question, and I'm very frequently asked this. So as we typically quote that the congenital heart disease, it's 1 in 100, so the risk in the general population is around 1%, and this is a spectrum of congenital heart diseases. If one parent has congenital heart disease, the risk is higher than the general population, and we usually quote 2 to 5% depending on population-based studies, and that's the information we provide to our patients. So we do look for congenital heart disease in our patients, and we recommend a fetal echocardiogram. But the message is the risk is increased compared to the general population, but it's not a 50% risk or a very high risk like in other, genetic, unless there are some underlying genetic conditions. Yes.
Well, it looks like we are coming to the end of our hour. I want to thank Dr. Bellows and Greer and Dr. Duarte for joining us this evening. I think everyone has learned a whole lot about pregnancy and congenital heart disease. Before we go, I want to remind everyone that we will be having our open house meeting for the PCORI group. What we're looking for is CHD patients from underserved and underrepresented areas of Texas and neighboring states. And we are with special attention to disadvantaged socioeconomic status and underrepresented ethnic and cultural backgrounds. This is a really exciting opportunity for patients to have a direct impact on the future of congenital heart disease care. So we hope you can join us for that open house. And I look forward to seeing everybody on our next episode of CV Live.
Thank you.
Thank you.
Thank you. Thank you, Greer. Thank you, Dr. Bellows.
Take care.
Bye-bye.